Very good evening to all of you. The topic of my presentation is advancing the wound healing, especially in the diabetic foot ulcer. How exactly a non-pharmacological agent like the photobiomodulation therapy, or most commonly we call as the laser, acts on the biofilm and also helps in promoting the wound healing. This is the clinically we have been discussing from the morning. There is a multiple type of conditions, or the diabetic foot ulcers or the other type of ulcers are coming to the clinical practice. It's always a challenging to the clinician, and most importantly, the multimodal or the multidisciplinary team is very, very essential in managing these type of conditions. Diabetic foot ulcers, I'm not going to the details of this. This is the most important changes. Usually in the chronic wound, they have a lower mitogenic activity, high level of cytokines, high level of proteases, lower level of growth factors, and suppressions of the angiogenesis or the new blood vessels formation is always challenging. Therefore, this is the most common reason for the delayed wound healing in any of the conditions like diabetics or the venous conditions or any immunosuppressive conditions, or in cases like the patients with the long-term challenges. The biofilm is one of the important factors for the delayed wound healing process. It's usually healing by creating a resistant microbial community that interferes with the normal healing process. Most importantly, as the biofilm starts developing, it starts its own self-regulated the metalloproteogenesis, or usually they are mainly the challenges for the delayed wound healing. This is the stages in which usually the classification of the ulcer is very, very important before we start the management. And also normally you use the University of Texas diabetic wound classifications basically for the prognosis of the wound healing. Among the various type of management, the photobiomodulation therapy or the low-level laser can be used as one of the adjunct modality, or in some conditions it can be used as an independent modality in the management of the wound healing. In my subsequent presentations, with the few examples, I will highlight how exactly it worked along with the other standard care, and also in some conditions, the foot ulcers, it is important for us to understand the maximum pressure area of the specific area of the plantar surface of the foot. Normally, in all this diabetic foot, there is a significant increase in the maximum plantar pressure. Therefore, along with all the standard care, offloading is must, thereby we relieve the load on that specific or the targeted area. So whenever we assess the wound, it is important for us to do the detailed clinical assessment of the wound. When we say that wound assessment can be divided into the four important aspects, one is looking at the wound bed, second one is the wound surface, third one is the wound peri-wound surface area, and also look for the wound assessment with respect to the location and other aspect. If you look at any chronic wound, you have to look for the granulation or whether the wound can be able to heal. If you see in the first ulcer, if you look at the wound edge is completely completely disconnected with the underlying surface. Therefore, the focus of our treatment should be, this is a pressure ulcer. The first important thing is the wound edge needs to be fixed to the underlying surface, thereby the promotion of the wound contractions would be better. When you look at the wound surface, if you look at in the second area, whether it is a necrotic or whether it is a granulation tissue is there, or even in the wound bed, whether there is any neoangiogenesis or the new blood vessels are present. Then the next important thing is looking at the peri-wound surface area, focusing on the skin color, as well as most importantly looking at whether there is any type of edema, the tissue edema, non-pitting or the pitting type of edema around the wound surface. Then the next important thing is where exactly the wound is there. The location of the wound is very, very important, and the dimension and the depth of the wound is important, because the location, especially in the plantar surface of the foot, when we are focusing on the neuropathic ulcers or other type of ulcer, the offloading strategy needs to be very, very essential with all other line of management. The photobiomodulation therapy, this is one of the established modality in the developed countries. It's either, as I mentioned, it can be used independently or in combinations with the standard care. Basically, it is the laser therapy, it works on the principles of the biostimulation. Basically, when the light acts on or irradiated on the tissue, Basically, it acts by the photochemical as well as the photobiological reaction. Therefore, when you treat with the photobiomodulations or the laser therapy, the most important thing is the treatment dose. Most of the time in the clinical practice, we say that we are treating with the laser, but it is not working. The reason is the appropriate dose is not decided according to the type of the ulcer, the nature of the ulcer, the location of the ulcer, and the size or the depth of the ulcer. These all the most important factors needs to be taken into consideration when we go for calculating the treatment dose of the laser. As I said, there are standard dose based on the various literatures or the studies we have established with respect to the various types of the lasers we used in the clinical practice. The first one is the helium neon, or the normally we call it the aluminum phosphide laser. It comes in the visible range. Usually the dose will vary up to the 3.5 joules per area. Suppose if you are treating with the gallium arsenide or the gallium aluminum arsenide laser, either it may be invisible laser or the infrared laser, the dose range will vary. I just wanted to highlight that we have conducted the translational research with the photobiomodulation therapy. Before we start applying this modality in the clinical practice, it is important for us to establish the evidence. For that, we have developed first we conducted this study on the animal model, where induced the diabetes, induced the neuropathy, then induced the diabetic foot ulcer, and then we took the various doses and irradiated for the specific time. Most importantly, in this, we have taken the one important outcome measure called the matrix metalloproteinases. This is especially the MMP1 and then MMP9 we have tested in this the animal model with the different doses, because MMP1 and the MMP9 are very, very important in the wound contractions or the healing of the chronic ulcers. As I said, the biofilm, when the self-regulated biofilms are formed, or the metalloproteases are formed in the wound, actually they try to deregulate or increases the MMP1 and MMP9. Unless you control the MMP1 and 9, the wound healing process gets delayed. Therefore, in this trial, we specifically selected the different doses of laser and then tested on the wound, the animal ulcer, and the various doses, and also we did the histopathology as well as the various biomarker analysis, including the MMP1 and 9. What we observed in the clinical practice is that a diabetic foot ulcer, usually in the inflammatory phase, MMP1 levels were significantly increased, but as we start treating them in the proliferative or the remodeling way, the laser helps in normalizing or down-regulating the MMP1 and 9. Thereby, it helped in improving the wound in an early time as compared to the control group. And most importantly, under the diabetic wound condition, excess MMP are expressed, which leads to the enhanced degradations of the extracellular matrix. Within the extracellular matrix, an imbalance of these matrix proteins and their inhibitor may cause degradation of the matrix, resulting in delayed wounding. Whereas especially with the applications of the laser, we can able to facilitate the removal of the excessive extracellular matrix, thereby helping in the lower level of MMPs, thereby increasing the wound healing time. This is the possible mechanism. I will go in, and the laser, this is all the cellular level mechanism by which the laser works. It helps in proliferations of the human endothelial cells and the fibroblast mediated pro-collagen production. It also helps in the cellular functions, neoangiogenesis. All these are the cellular level benefits with the applications of the low level lasers. In the next few slides, how exactly the laser can work in the clinical practice, either independently or with the combination with the standard care. If you look at this ulcer, this patient is having a multiple problem. He is having a chronic the diabetes for more than 20 years, having all the end organ complications like neuropathy, nephropathy, as well as the retinopathy. And the patient was on dialysis and bedridden, and surgeon said, I will not be able to take the risk of the grafting the patient. We independently treated with the minimum standard care and with the offloading strategy and with the early mobilization, By 6 weeks, we were able to completely close both the ulcers of these patients without any other additional or the advanced modalities or the advanced adjunct therapies. The second one is the patient also had the diabetes with the peripheral arterial disease and peripheral vascular disease, both the arterial and the venous disease. This is a venous ulcer. This was also treated independently. The next important thing also, this case is a very interesting case. This is a pressure ulcer. This case also almost 25 years back case I am telling. Still she is coming to the clinics to meet us and then grow, because when maybe just 2 minutes I will take on this case, because she was actually undergone cesarean section in one of the nursing home. During the C-sections, she developed a hypovolemic shock. Then she came to the tertiary care hospital with the unconscious status, that our center. Patient was in the ICU with the mechanical ventilator, with the tracheostomy and all other advanced care for almost 31 days. Then finally she was recovered. But during the course of her ICU stay, she developed a very significant the sacral ulcer, having a grade 5 sacral ulcer, exposing the bone, and the same time the surgery, because she was just recovering, and when the anesthesia consultation was given, because the overall the immunity level was very, very low, the anesthesiologist said we will not be able to take the risk for the next few weeks. Then this was we have treated with her lasers, especially with the combinations of the 2 different wavelengths. And if you see this case also, by 28 days, we are able to completely close the ulcer, and at the same time, because she had a very severe critical care IC or the acquired neuropathy, with the proper rehabilitation, patient walked out of the hospital, and still now she is and most importantly at the end she said 3.5 months she did not see her baby, because on the day of delivery she developed a hypovolemic shock and became unconscious. After 3.5 months she saw the baby in our own center, and then she was discharged from the hospital. So this is the another cases where combination of interventions, by 39 days we were able to completely close the ulcer. So this all the different types of ulcers were completely healed. Okay, with this I will summary. Actually the laser can be, or the photobiomodulation therapy can be used independently or in combinations with the standard care. And the clinical decision making, the most important thing is the appropriate dose calculation is very, very important. Most of the time in the clinical practice, sometimes we get the feedback that we are using the laser, but we are not getting the result, because the selection of wavelength, the selection of the dose, the application of the method, the number of days you required, everything needs to be planned in the beginning. Accordingly, we need to taper also, because in the initial time, when the inflammatory phase, before we start the neoangiogenesis, the dose needs to be little higher. As the new blood vessel starts developing in the wound bed, you have to taper the dose. Or in the remodeling or in the maturation phase, we have to standardize the dose. Otherwise, at the end, sometimes if the dose also becomes very excessive, in this ulcer, if you see, we were kept little higher dose till the end, because there was absolutely no tissue. We wanted the wound to be closed completely with the scar. Therefore, according to the need of your the healing process, we have to taper the dose, and definitely if you calculate the dose properly, it works very well in the diabetic foot ulcer. Thank you all.
Thank you, sir. We will not be taking questions. I am so sorry, sir. Yeah. Okay. Can I now request Dr. Srinivas to please present a small memento to Dr. Arun Maiya. Meanwhile, our next speaker for the day would be Dr. Ravi Vyas. He will be speaking on a problem which many of us face on a day-to-day basis. I was just discussing with him, polysystemic infections in diabetic foot. Thank you, sir. So Dr. Ravi Kumar Vyas, he hails from Mysore, has come all the way from Mysore to speak on the topic of polysystemic infections in diabetic foot. Over to you, sir.